TMC Mumbai. Welcome, madam. And as chairperson, we have a eminent radiologist, Dr. Amit Chaudhary, who is also a professor of radiology at TMC Mumbai.
Geeta, your slides are not moving.
Yeah.
Really? It's not moving?
Yeah.
That's okay.
Just click in the center, it will move. Click in the center of the slide.
Is it moving now?
It's okay, ma'am. You just go to the students list.
Yeah.
Yeah.
So we have nine students to be part of this live seminar. 5 have joined. Students, please, you can introduce yourself according to the list. Dr. Srijani, I think, is present.
Yes,
Can you
ma'am.
introduce yourself?
Yes, ma'am. I'm Dr. Srijani from PS Medical College, Kuppam, second year resident.
Dr. Shivangi?
Good evening, everyone. Jivangi, a second year postgraduate resident from Department of Pathology, PG Medical College, Ahmedabad.
Dr. Preeta?
Good evening, everyone. I'm Dr. Preetha, third year resident from Maharashtra's Medical Campus, Kathmandu, Nepal.
Dr. Vivek? Dr. Ekta? So today's session with me, Dr. Urvi, who's assistant professor at Department of Pathology, PG Medical College, Ahmedabad, are there. And the webinar hosts are Dr. Sumit Gujral and Anita Burgess, madam. There are some reminders in case of connection interruption or no sound or video, please kindly rejoin after leaving the meeting and answer the poll questions in the chat box, and do not send requests for annotations to the presenter. Few disclaimers, few others. We have 2 more slide seminars coming up. Next one by Dr. Shilpa Rao on adult type brain tumors, and the third one, pediatric type, which will be given by Dr. Neeta Chakra. Dr. Ayushi?
Yeah.
I'll stop sharing.
Yeah, so is my screen visible?
Yes, ma'am.
Yes, ma'am.
In the full screen mode?
Yes, perfect.
Yes, ma'am.
Okay, so I will just give a brief introduction about the CNS embryonal tumors, and Dr. Amit will chip in with inputs from radiology, and then we will start the from case 1. So what are CNS embryonal tumors? I will cover what they are, why do we need to diagnose them and individually identify them, and how do we do that. So embryonal tumors, for those of you who routinely do report brain tumors, it will not be a surprise. But for those who are not regularly seeing brain tumors, they are a collection of tumors which share a tendency to disseminate via the CSF pathways, and they histologically, at least partially, are composed of what are known as small round blue cells within the CNS. They have scant cytoplasm, and then they are densely packed with high degree of mitotic activity, and all of them are CNS WHO grade 4. That means CNS WHO grading 4 implies the highest grade of malignancy that a CNS tumor can have. They account for around 20 to 25% of CNS tumors in children. If you see the age group in which they occur, the highest incidence is in less than 5 years. There is still some amount of brain tumors that occur in 5 to 9 years, but it goes down between the ages of 10 to 19. That is the adolescent or young adult age. The incidence goes down. And the most common and prototypical of embryonal tumors that generally you know even from your undergraduate days is medulloblastoma, which by definition is an embryonal tumor that arises in the posterior fossa. And it is the second most common malignant brain tumor of childhood. The other embryonal tumors are actually less common. Most common of the CNS embryonal tumors is medulloblastoma. And how has the classification of the CNS embryonal tumors evolved? It started way back when there was a first histological description of medulloblastoma way back in 1910. But the term medulloblastoma as a cell arising as a blastic phenotype arising in the fourth ventricular posterior fossa was a term coined by Cushing and Bailey in 1925. Since then, the term just existed in the mostly the neurosurgeons and neuropathologists handbooks, but it made its way into the official first WHO classification that was published in 1979. And since then, successive classifications have all included the term medulloblastoma. In 2014, there was a lot of changes happening in the world of neuropathology, and International Society of Neuropathology came up with combined guidelines for giving diagnosis or classification of brain tumors, combining the histology that we were routinely seeing till now, as well as including a lot of molecular information that was exploding all over the world, and a lot of information was gathering. They tried to combine all of these things together in 2014 and issued guidelines that how can you give an integrated histomolecular diagnosis or classification of brain tumors. So this made its way into the 2016 WHO classification, which instead of histology, the first time they introduced histomolecular groups of the classification. Then subsequently, around the same time, there was also a very seminal paper in which there was a terminology in CNS called CNS-PNET, primitive neuroepithelial tumor of the CNS. In that, any kind of tumor, that was a small round blue cell tumor outside the posterior fossa, it was all called as CNS-PNET by the pathologist till then. But it was a very good paper which showed that if you do the genetic testing of all whatever was called as CNS-PNET, a whole host of different entities emerged. That there is no such thing called PNET. All of those what we used to call as PNET actually classify as some or the other different glial or non-glial or embryonal entities. And accordingly, they were because of this classification, the term PNET was abolished from the CNS classification in 2016, and a lot of new entities made their entry what was identified based on this paper. So in 2000 till 2007, what you had was only morphological classification of embryonal tumors. So you had medulloblastoma of different types, that is histological types of desmoplastic nodular, extensive nodularity, anaplastic, large cell, and then there was this term CNS-PNET, which also had a lot of other embryonal tumors like neuroblastoma, ganglioblastoma, medulloepithelioma, ependymoblastoma, and ATRT. Only these entities were described. But in 2016, subsequent to all this molecular information, there was a shift in the classification, and now the medulloblastoma could be genetically defined or histologically defined. The histologically defined was kind of similar to what we had seen previously. They called it classic medulloblastoma, desmoplastic nodular, medulloblastoma with extensive nodularity, and large cell or anaplastic features. But they also introduced the term genetically defined according to three major subtypes and two subtypes of the genetic alterations identified. and this term PNET was removed. What happened in 2021? They have in the current classification that is followed, the term histologically defined has also this as a separate entity has been removed. It is just medulloblastoma histologically defined, which can be any of the 4 patterns that was there previously, and then molecularly defined you have these various subtypes, which can be Wnt activated, SHH activated, P3 wild type, SHH activated, P3 mutant, and what is called non-Wnt, non-SHH, which do not belong to either of these categories. And then you have the other embryonal tumors, of which of course you are aware of ATRT, atypical teratoid rhabdoid tumor, and then there was this entity, the embryonal tumor with multi-layered rosettes, CNS neuroblastoma, which is also given a genetic identifier of FOXR2 activated, and another tumor called CNS tumor with B-core internal tandem duplication, and then there was the NEC. Now, when do we call NEC and NOS has also been defined? NOS is when no genetic testing has been done. So you can, if there is no testing and you're not sure what it is, you can call it a CNS embryonal tumor NOS. And NEC, that even after all sorts of genetic testing has been done, but you're not able to fit it into any of the categories, it becomes a not elsewhere classified NEC. So this kind of new classification has been introduced, which is currently being used for embryonal tumors of the CNS. And why? This has shown a better correlation with biological behavior and has shown that in this manner, if we report it, they are able to implement new therapies and target actionable alterations. So this has been the categorization, the earlier classification, then came the PNET, and then which was further made its way to medulloblastoma. It was histologically defined, genetically defined, and then newer entities were introduced. And right now, if you see, there is a lot of subgrouping based on the molecular alterations that can be identified. Even further subgrouping of these individual groups into smaller groupings is proposed. But as of now, this much is relevant. But why do we need to classify this? It is there. All these embryonal tumors are grade 4 tumors. Doing such extensive molecular testing to arrive at the diagnosis is time consuming, and of course, to say nothing of the cost. So why do we need to classify this? Now, the thing is that this grading, CNS WHO grade 4, was given originally when these tumors were detected based on expected outcome without treatment. That this kind of a CNS embryonal tumor, if you do not treat, the patient is going to die very soon. So that is why they were given the grading as CNS WHO grade 4. But with treatment, the grading of different types of these tumors, the behavior of different types of these tumors is different. But the grading was originally given based on any other outcome without any treatment. Then, but with treatment, the grading, the behavior of the tumor is quite different. That is why we need to classify. And histologically, except for the larger anaplastic morphologies for medulloblastoma, there are no other predictors of outcome. But if you do genetic testing, you are able to predict the outcome in many of these cases. Then also, this molecular classification shows better correlation with behavior and prognosis, as I said. And also, if there is any association with the hereditary cancer predisposition syndrome, which you can only give by genetic testing, then you need genetic counseling and routine screening and evaluation. Also, as I said, you can implement targetable therapies if you identify those mutations. And also, there is introduction of the concept of escalation or de-escalation of therapy depending on risk. So, if suppose on basis of molecular testing, we are able to say that though this is a grade 4 tumor, but it has low risk of recurrence, then maybe we do not need to give very high doses of chemotherapy that have routinely been given. And conversely, if a tumor turns out to be very high risk based on the molecular testing, then we need to give aggressive therapy. So, we can also tailor the extent or the aggressiveness of therapy based on the molecular classification. So the even differentiation among entities, if you see among the various entities within the embryonal tumors also, if you have the medulloblastoma, there are the prognostic 5-year survival rates of medulloblastoma vary from 40 to 90% depending on subtype, but the ATRT and the ETMR still have very poor prognosis. And so that is also the reason that you need to segregate or identify between these various entities. So this is just to show what used to be the previous risk stratification of medulloblastomas some years ago, that you had the clinical factors, what is the age, what is the size of the residual tumor after surgery, and whether the tumor metastasizes or not. But currently, this is the risk stratification used by clinicians right now, that if you have the various subtypes of medulloblastoma, accordingly, if you have a Wnt or there are certain types with some kind of chromosomal alteration, then you have a low risk. If you have this SHH or group 3 without any adverse features, or certain types of group 4, which is the non-Wnt, non-SHH subtype, then you have standard risk. Then you have the high risk if you have certain other features, and very high risk if you have certain other features. So according to this is currently the risk stratification that is used by clinicians for treating these patients. Hence, we really need to classify and try to reach at a diagnosis. Also, as I said, that there is an attempt that because this Wnt activated medulloblastoma has shown very good response, like there is more than 90% survival, especially in younger patients, then what outweighs the diagnosis is concerns regarding late toxicity in long-term survival. So basically, these patients are surviving long. If we give them very high risk, very high dose of chemotherapy or radiation at that young age, then they are going to have long-term toxicity, defects in cognition, defects in understanding, their future quality of life might be impacted. So there have been attempts to de-intensify this therapy at this young age in these patients who are likely to behave well. There are several trials undergoing for this reduction or de-escalation of therapy in Wnt tumors. Now, we have seen what are these and why we need to classify, but how do we classify? Because all of them look like what? You are swimming like in a sea of small round blue cells. So this is what it looks like. All the small round blue cells, they all look like each other. All the tumors look like each other. So how do we differentiate between them? So if you see this screen, you can see that there is a whole sea of small round blue cells that I have shown to you. And none of these is an embryonal tumor. So in the CNS, you can have a lot of tumor that can have small round blue cell morphology, and not all of them are embryonal tumors. So you have to be aware of, except for the medulloblastoma or pineoblastoma, rest all are, you have different types of high-grade glioma or metastasis also that can look like the CNS embryonal tumor. So you have to be aware of these entities. And how do you separate between them? You have to go through the clinical and radiological parameters. You will hear more about this from Dr. Amit. Then you have to apply your basic histology, and with the help of immunohistochemistry, you can kind of start differentiating among these various small round blue balls. And then if you add a layer of molecular evaluation, if you have it, great. If you don't have it, if you're able to get it done from a central reference lab, then yes, you are able to dissect out all these various types of tumors from each other, and then you can give an integrated diagnosis. So just a bit of the clinical and radiological background. As I said, you have to know that most of these tumors, like though medulloblastoma, they occur in young age, but there are different subtypes of medulloblastoma can peak at different ages, and you can even have around 25% of them in adults. ATRT is usually tumor of infancy in less than 3 years, similar for ETMR, embryonal tumor with multi-layered rosettes. Also, as I said, by location, medulloblastoma is a tumor of posterior fossa, and most of it is in the cerebellum and to some extent in the fourth ventricle. ATRTs can occur in the cerebellum, but also they can occur in the supratentorial region of the spine, and ETMRs usually occur in the cerebral hemisphere. Radiological features also of most of these tumors have been defined, which Dr. Amit will describe in greater detail. You should also note that based on the genomic signatures, like the genetic signatures of different medulloblastoma, there's an entity called radiogenomics, in which with the help of radiological features of all these major entities, the neuroradiologist can predict which type of medulloblastoma this is likely to be, and you can have a very good correlation with your histopathology in such cases. Then coming to the basic morphology that you look for in these tumors. Now, as I said, they're all small round blue cell tumors, but not all of them are really round. ATRTs can have admixture of large rhabdoid cells, and sometimes even you can see teratoid elements. So what you see in teratomas outside the CNS, so those kind of teratoid elements like cartilage, gland, bone formation, all these sometimes it doesn't always occur in a minor proportion only. That is why historically it was called a atypical teratoid or rhabdoid tumor. But yes, if you have it, then it can be a helpful feature. Also, there are certain tumors such as the medulloblastoma with desmoplastic nodular architecture or MBEN which have classic pattern that can help identify them. If you have ribbons and trabeculae, then the medulloepithelioma, which is now called an ETMR, you can kind of make a provisional guess. And if you have areas with myogenic differentiation, then medulloblastoma. Besides this, of course, you must have learned about rosettes in all your classes, that you can have different types of rosettes. So Homer-right rosettes are seen in which tumors? Mostly medulloblastoma, pineoblastoma. Flexner winter type of rosettes classically seen in retinoblastoma. Then two ependymal rosettes, so which is you can see in here. You can see it here. Basically, it's a rosette with a central lumen, while a Homer-right rosette has central fibrillary material. And two ependymal rosette is seen in ependymoma, which is many times a differential with these embryonal tumors. Then, of course, perivascular pseudo-rosettes, you must have heard a lot. You can see them in ependymoma, but also in a lot of other tumors. And then what is called as a pineocytomatous rosette. This kind is a kind of neurocytic rosette that you see in pineoblastoma, and neurocytic rosette seen in neurocytoma. So this kind of rosettes you have learned in different in the round cell tumors, I'm sure, in the soft tissues also. So similar principles apply in the CNS as well. Now, with the immunohistochemistry, first of all, when you are trying to subtype an embryonal tumor, you have to confirm whether it is an embryonal tumor. As I said, a lot of other round cell features can be seen by a lot of other CNS tumors. So you have to do a panel of IHC to exclude the mimics and know that you are dealing with an embryonal tumor. So in general, the panel that is used is composed of NUN, which is a neurocytic or neuronal marker. Synaptophysin, as you know, is a good neuroendocrine or neural marker. GFAP to highlight the glial tissue. EMA is helpful for ependymomas. And if you're trying to rule out gliomas, you need to do the IDH, ATRX, L1 cam again for ependymomas. And sometimes if you know if you're suspecting metastasis, you can even do an A1, A3 or A for ATRT. Then, of course, the characteristic loss of INI1 or BRG1, which is diagnostic of atypical teratoid rhabdoid tumor. And then you have some certain surrogate IHCs which can be used as surrogate for molecular testing. For example, there's a Lin28 IHC, which is surrogate for ETMR C19 alteration. So that can be used as a surrogate. If it's diffusely densely positive, then you are pretty sure that you are dealing with the ETMR. Then also for the medulloblastoma subtyping, a host of IHC panel has been developed, which can, by using a different combination of these IHCs, or the result of these IHC, you can subtype the medulloblastoma into a Wnt SHH or non-Wnt non-SHH. So these are like GAB, YAP, beta-catenin, LEF1, OTX2, and PP3. So these are the IHCs that can be used as surrogates for molecular testing. But you have to be aware of pitfalls in when you start interpretation of these IHCs. Besides this, in addition, we have testing platforms of FISH and sequencing for certain type of genetic alterations within these tumors, which can help you know that, first of all, confirm the diagnosis, as well as they can help predict the risk of behavior. I will not cover this in detail, since this is basically just for your awareness that in addition, FISH and sequencing can give you a lot of molecular information without doing very high-end genetic testing. So if you add all these things, including IHC, which is simple, reliable, and more easily available, and to some extent, FISH is also available across the country in many places these days. So then you'll be able to do a simple and reliable classification of medulloblastomas or most of these tumors. And the other high-end tests like NGS, RNA profiling, gene expression profiling, and methylation assays, they are very high-end, high throughput and evolved methods. If you do not have them, and if they are available or required, if the previous methods fail, then only you can refer them to a higher center for these kind of testing, so that you can arrive at an integrated diagnosis. So before we start here, I think I will ask if Dr. Amit is there, and yeah, I will stop screen sharing, and Amit, yeah, you can share your screen. So I hope the introduction of embryonal tumors was clear to everyone, and we will hear more about the clinical and radiological part from Dr. Amit. As you know, CNS tumors, almost all of them will require a good amount of radiological input. Just like bone soft tissue tumors, CNS tumors are also tumors in which because we only get a little small part of the tissue. Most of the time, because it is in the brain, the surgeons are only able to take out a little part of the tissue. So we do not have the representation of the whole tumor as you would have in other tumors of the body. So here is where the importance of radiology comes in. That you are, with the help of radiology only, you can kind of make a good guess that small little tissue represents what type of the whole tumor. So Amit.
Okay, shall I share my screen?
Yes.
Yes, sir.
Okay. I hope my screen is visible, and yeah, I hope the presentation is visible now.
Yes, yes.
Okay, so I will quickly rush through a few slides as to how imaging can be performed. So MRI is the workhorse for imaging of the CNS tumors. This is because of its very high soft tissue contrast resolution, which has a better advantage over any other modalities. The other modality, of course, being the CT scan. That being said, MRI is relatively time consuming compared to CT scan, and other advantage of MRI is that it doesn't have any ionizing radiation. So as far as imaging indications go, we use MRI for tumor detection, tumor characterization at times, looking at extent and grade of the tumor, then targeting the optimal biopsy site, or at least giving the surgeon an indication or direction as to where the optimal site of biopsy would be. Thereafter, for surgical planning purpose, and followed by surveillance, that is for post-treatment follow-up. So the classic MRI brain tumor protocol includes what is known as a T1 weighted image, a T2 weighted image in axial and coronal planes, gradient or susceptibility weighted imaging, followed by diffusion weighted imaging, followed by what is known as perfusion imaging or dynamic susceptibility contrast imaging, followed by T1 post contrast, T2 flare post contrast, and other advanced imaging sequences which include MR spectroscopy, DTI tractography, and bold fMRI, which will be used for surgical planning. So this is an example of a T1 weighted MRI image, wherein one can appreciate that the white matter is white, the gray matter, that is the deep gray nuclei, and the cortex is gray, and the CSF is dark or hypointense. So that is how a classic T1 weighted image appears. And there are typical tissues or signal characteristics of certain tissues which can be seen on T1 weighted imaging, and these appear bright or hyperintense on T1, which include blood, fat, and protein. And often one can also detect alveolar metastasis against the bright background of diploic space, marrow, fat. So this is an example of a brain tumor. We can see that this is the tumor present in the right frontal deep white matter in parasagittal location, and this is a T1 weighted image. This is again because the white matter is white and the gray matter is gray and CSF is dark. But in addition, we can see that there is some bright area on this in this tumor, and in this highly aggressive tumor, this area is actually blood within the tumor. This can be confirmed by another sequence which we use for looking at blood or blood products, which is the gradient imaging, wherein the blood products would appear dark. So that confirms the intratumoral bleed or hemorrhage. Next sequence is T2 and flare. So this is again used for looking at location and extent of neoplasm, as well as for looking at any subarachnoid hemorrhage, especially the flare sequence, or for leptomeningeal seeding, for which we classically use post-contrast flare imaging, as it is a highly sensitive sequence for diagnosing any leptomeningeal metastasis. So that is a flare sequence. to tell you what is T2. So T2 is a sequence wherein the contrast is reversed compared to T1 weighted imaging. So the white matter is now gray, but the gray matter is white or brighter. That is the deep gray nucleus, the putamen, and the cortex, which is bright or hyperintense. And the CSF is even brighter. So CSF is completely white or hyperintense on T2 weighted image. A flare image is a modification of T2 weighted image wherein the fluid signal, that is the CSF signal, is suppressed so that certain pathologies are brought out to a better advantage. So again, here we can appreciate that the gray matter is white matter is gray, and the CSF is suppressed compared to a T1 wherein the white matter would be white, gray matter would be gray. Okay? Let us see an example. So this was a patient with a midline glioma, wherein we can appreciate that there is this heterogeneous tumor which is present in the left basal ganglia as well as thalami. And in addition, we can see that the sulci, which are normally dark or hypointense on flare imaging, show these streaky areas of enhancement, implying there is leptomeningeal disease. So that is one good utilization of flare. Likewise, this imaging can also be used for surveillance in post-treatment follow-up scans. Thereafter, we have diffusion-weighted imaging. So this is a sequence which leverages the free or Brownian motion of water molecules in the interstitial spaces. In the cases of tumors, these, especially round cell tumors or round blue cell tumors, these interstitial spaces are tightly packed so that they hinder the free Brownian motion of water molecules. And by means of using this sequence, which is known as diffusion-weighted imaging, we can appreciate that highly cellular tumors tend to cause diffusion restriction. That is, these appear brighter or hyperintense on diffusion-weighted imaging. And we have a corresponding what is known as ADC map, that is an apparent diffusion coefficient map, wherein what is truly restricting would appear darker. So what is bright on diffusion-weighted imaging and dark on ADC maps is actually showing true diffusion restriction. Again, these can also be used for looking at infarction, especially in the post-operative period. Thereafter, we have T1 post-contrast imaging, wherein we can appreciate that certain tumors, especially higher grade ones, tend to have what is known as break in blood-brain barrier, and they would demonstrate what is known as enhancement, or again appear brighter, or show what we call as post-contrast enhancement on a T1 patch side post-contrast image. That being said, there can be certain tumors, like even certain round blue cell tumors, which may not show as florid an enhancement as certain other tumors would. Thereafter, we use advanced imaging for typically for grading of malignancies, that is calling a malignancy as a high grade vis-a-vis low grade malignancy. And then we have, of course, FMRI, which is used for surgical planning, which involves DTI and tractography, as well as BOLD, that is blood oxygen level dependent FMRI acquisition. So that was in a nutshell about what sequences and protocols one would use for brain tumor imaging. This will be similar for adult brain tumors as well as for pediatric brain tumors. So Dr. Ayushi, that was in brief about the MRI brain tumor protocol, and perhaps we'll now move to the cases wherein we'll look at a couple of examples of round cell tumors or embryonal tumors.
Yes. So if you stop share, I will start sharing my cases, and we will go through the cases one by one. So I in the presentation that I shared in advance, there are some cases in which, along with the history, we have shared some radiology. In a few of those, we have added the radiological some few images, which Dr. Amit will explain to you according in the background of all that he just showed you. So thanks, Amit. That was very nice, brief, good encapsulation of the basic sequences that we see. So actually, why is it important for the pathologist? As I said, you have to be able to understand what the radiologist is saying and trying to convey that where they are saying there is high cellularity. What does that mean for you as a pathologist? Are you getting the part that they have mentioned in radiology? Has that sample reached you or not? Because as I said, the sampling in the brain is limited. So something that they have said is a very high cellularity tumor, but what you are seeing is very low cellularity glial tissue. Then the tissue you have might not be representative. So that way you have to correlate with the radiology many times to be able to arrive, and it helps in a lot because we have limited sampling and a differential in small amount of tissue, again just a round cell tumor. But if you correlate with the radiology, the location and the extent of the tumor as given by the radiology, sometimes you can make a better educated guess about the possible differentials. And it is very important to be able to talk to a neuroradiologist and get this information from them and understand what they are trying to say. So we start with the first case. The screen is visible, I hope.
Yes.
Yeah. So this was an 18-year-old male who had a headache and vertigo with a short history. Amit, you like to tell about the MRI?
Sure. So if you can identify, this is the T2 axial MR image, the image above, and the image below is a T1 post-contrast image. So as Dr. Ayushi alluded to, in the posterior fossa for looking at embryonal tumors, of course, we'll be demonstrating mostly embryonal tumors because this is an embryonal tumor talk. So we look at features like the location of the tumor, then the enhancement pattern of the tumor, and then metastasis associated with the tumor, which can help in narrowing down the differentials of round cell tumors or embryonal tumors in the posterior fossa. So as can be seen in the image above, we appreciate that there is an abnormal mass which is present in the predominantly in the left cerebellar hemisphere, and it is T2 hypointense or isointense to the gray matter. So this is an indicator of high cellularity in a tumor, which is usually or almost always the case in embryonal tumors, that is small round blue cell tumors. So this is one feature of high cellularity and embryonal tumor. And then we have this heterogeneous enhancement again within this tumor. So this is highly suggestive of an embryonal tumor like a medulloblastoma. Was that kid an 18 months old kid?
18 years. 18 years.
18 years. Okay. So that is a feature of medulloblastoma. Now on the second slide, this is a companion case wherein again we can appreciate in the midline in the image which is labeled as T2, there is a large mass which is present in the posterior fossa or cerebellum in the midline. Again, this is iso to hypointense on T2, implying its highly cellular nature. In addition, we look at the diffusion weighted imaging and we can appreciate that the tumor is bright on diffusion weighted imaging, and on corresponding ADC maps, it is dark, implying there is diffusion restriction, which is again another feature of high cellularity in embryonal tumors. And on gradient imaging, so we use this sequence for looking at any intratumoral bleed or calcification. So here we don't see any dark areas. Bleed or calcium would appear dark on gradient or SWI images. We don't see those dark areas. So that implies that there is no bleed within the tumor. And on T1 post-contrast image, in this case, we see this florid post-contrast enhancement. So medulloblastomas tend to have very variable enhancement. Usually SHH type of medulloblastoma has a very florid enhancement, whereas the non-WNT, non-SHH type seldom enhance as much as SHH or even WNT medulloblastomas would. So given this appearance, the possibility of a round cell tumor like a medulloblastoma can be considered in the posterior fossa. Of course, if this patient is a kid who is under 2 years of age, or if the patient patient is under 2 years of age. The other important differential to be considered is ATRT with this kind of appearance. The other two common differentials in the posterior fossa, especially in pediatric age group, include an ependymoma and a pilocytic astrocytoma. So both these tumors do not show diffusion restriction, which is usually a feature of round cell tumor because those tumors may not be as cellular or the intercellular spaces aren't as tightly packed as they are in round cell tumors like medulloblastoma or ATRT. So that is one feature which helps us in differentiating a medulloblastoma or ATRT from ependymoma or a pilocytic astrocytoma.
Yeah,
Over to you.
great. Thanks, Amit. Thanks. So, as Dr. Amit has very nicely explained the features to you and given the possible differential, so we will start with the histopathology of this first case. And since this is a relatively easy case, Ekta, would you like to take it? If Ekta is not there, then Shivangi.
Yes, ma'am. So this is actually showing at a low power that the tumor is very much, the lesion is very much hypercellular because it is looking very much blue,
Yes.
and which corresponds with the imaging findings. On low power, we can see that it is mainly of two types. We are able to see some moderately cellular nodular areas along
I think
with hypercellular areas.
So basically, you are seeing some nodular areas and
Yes, ma'am.
hypercellular areas in between. Yes.
Yes, ma'am. Yes, ma'am.
Yeah. So this at this power. Anything in addition?
The nodular areas, they were having moderate cellularity, and it looks like it is very more differentiated towards the neuronal sites. And the internodular area is a kind of hypercellular and might be suggestive of possibility of small round blue cells, kind of morphology in the internodular area.
Okay, so just to define this further, this is the nodular areas, which are, as she said rightly, they are less blastoid looking than these internodular zone, which are very undifferentiated blue cell, while these look more differentiated, smaller, regular, round, neurocytic like, neurocyte like. Even sometimes you can say like there's a clear space around it and oligo-like. So neurocytes, yeah. So neurocytes can also look oligo-like. So the more differentiated, more uniform, smaller cells, and with some amount of, if there was some, here there was some streaming in between, and there is some pale pink material here and there scattered in between. While here you are having a very undifferentiated round blue cells. So would you like to say anything about the width of these internodular areas? To the nodular areas? No. So if you see here that these nodules are separated, there are multiple nodules all around, but they are separated by these internodular zones, which are variable in thickness. In some areas, the internodular zones are quite wide, while in some areas, the nodular zones are a little bit back to back. Okay, so this is quite wide areas with a lot of undifferentiated cells, and in between across these, there are nodular areas interspersed. So Shivangi, what is your? And then of course, if you see this area, you can see again this kind of oligo-like cells and a little bit of fibrillary matrix, which is absent in this area. And I think I had highlighted some mitotic activity, but even I can't find it. But it was there in the internodular zone, but it was not there in the nodular areas. So differential, Shivangi, very straightforward case.
And so this is likely based on the clinical findings, radiology and histology. It is mainly suggestive of medulloblastoma, and that is desmoplastic nodular, most likely.
So desmoplastic nodular, yes, but also we should rule out a medulloblastoma with extensive nodularity. Yes. And then, so we are pretty sure it's a medulloblastoma. This is a straightforward histological diagnosis. Histological subtyping is can be done here, and you just have to, depending on the amount of the internodular septa or the thickening of the internodular undifferentiated cells, you can assess whether it is desmoplastic nodule or MBEN. Okay, so
yes.
So what IHC would you do would you do anything for confirmation, differentiation, anything?
Yes, ma'am. So first, I was suspecting that the nodular area has neurocytic differentiation. So I go for synaptophysin or new N, which is for neurocytic differentiation. And along with that, the internodular round blue cell area will also show some sort of neuronal differentiation. And the other IHC that I will go is for further dividing the medulloblastoma. That is for beta catenin. We can go for beta catenin, GAP1 and GAP1.
Okay. So yes, so synaptophysin. Very nicely highlighting strongly in the nodules, but it is also present to some extent in the internodular zones. New N is nicely present inside the nodules, and it is not there in the internodular zone. The new N is positively mature neuronal or neurocytic cells. And what I would have liked from you was asking for a reticulin, which is a stain that is present actually in most of the labs in the country. Yes. So how is that helping you here?
So, ma'am, the reticulin stain would positive and fine in the internodular area, whereas it is absent in nodular areas.
So that indicates that there is desmoplasia, where the reticulin is increased in the internodular zone. So these are the desmoplastic zones, and it is lost inside the differentiated areas. So if you are trying to differentiate between an MBEN versus a desmoplastic nodular, these three stains give a good that if you have a considerable amount of internodular areas, okay, then there is more likely that you're looking at a desmoplastic nodular. Yes, and if you have these nodules almost completely back to back with hardly any internodular zones, then you're looking at an MBEN. So why is this differentiation important? Can you tell me, Shivangi?
So, ma'am, actually, if if the patient is having extensive nodular, there is MBEL kind of morphology, it uses a very good prognosis. And
Yeah. So here also, if you see in the MIB, you can see that the nodules have very little MIB inside them. That is very less proliferation. They are more mature areas, while the internodular zones, you can see a lot of MIB. So this is the undifferentiated area. Now P53 is the other stain we would do in a desmoplastic or M-bend because it has certain molecular correlate. And yes, we did do a desmin here, but that was actually not needed. So the diagnosis was a medulloblastoma, desmoplastic nodular pattern. Perfect. So to further subtype it, we did what is known as STK27ME3, which shows that there is hypomethylation of the tumor, and we did CMYC, which is negative, so that is a good feature. And left one to rule out the wind type of medulloblastoma. The GAB, YAP, and all that we have not. I do have it. I'll show it later on. I will combine case 1 with case 4, so I can cover this whole spectrum of ICs with you. Now, difference between medulloblastoma and desmoplastic nodular we have covered. We'll start with case 4, and I will come back with the discussion for case 1 in a while. So, who would like to take this? Maybe Preeta, would you like to take this?
Yes, ma'am.
So first I will ask Dr. Amit to give the opinion on the radiology. I think I have limited images. I have limited images in this particular case. But this was a 5-year-old male with again a short history and with vomiting weakness in the right arm. And Amit, would you like to take the radiology?
Sure. So what we have been provided here are a T2 weighted image, that is the image above, and a T1 post contrast image. And what we can see is that there is again a large, relatively well circumscribed mass which is present in the right cerebellar hemisphere. It is again iso-intense to hypo-intense to the gray matter, and then it shows florid post contrast enhancement. So we have seen the location, lateral aspect or the cerebellar hemisphere, a lateral tumor, almost appearing extraaxial, abutting the surface of the cerebellum. If we look at coronal image, this tumor may even abut the tentorium. So when you see a posterior fossa tumor which is present in the lateral aspect of the cerebellar hemisphere, abutting the tentorium, or is surfacing in nature and has features of round cell tumor like a medulloblastoma, as the case here is, and I'm sure this would also show diffusion restriction or diffusion weighted imaging. This feature is highly suggestive of the SHH type of medulloblastoma. So a laterally located tumor in the cerebellar hemisphere touching the tentorium, showing extensive enhancement. Consider a possibility of SHH type of medulloblastoma.
Great. So Preeta, you're up next. So would you like to start with the description of the tumor?
So the section shows tumor cells which are arranged in diffuse sheets with no particular pattern.
Yes.
On higher power, we can see that these cells are large atypical cells which have high NC ratio. They have irregular vesicular nuclei, prominent nucleoli. And on further high power, we can see that there are few multinucleated cells, cellular molting, apoptotic debris, cell wrapping, and frequent mitotic figures are also seen. And they have high nuclear pleomorphism.
Yeah. So basically, a tumor that is not having pattern, you're not having any nodular areas at all. You're having completely diffuse sheets of cells. They look pretty uniform on this power, but as you get closer, you start seeing that there are a little bit pleomorphism is there. And though they look very round blue cell kind of tumor on the low power, as you go in high power, you realize that they are having many of them are having vesicular nuclei with prominent nuclei and some amount of cytoplasm also here and there. Besides this, can you tell me what this is?
It looks like cell wrapping.
Cell wrapping, yes. So besides this, you can also see a lot of apoptotic debris, and there was mitotic activity. So it is highly proliferating, highly apoptotic with a lot of pleomorphism, which you identified on going on a closer view, only on the highest power. Till the lowest power, they look like it is likely to be a uniform round blue cell tumor. But as you went closer, you realize that there is a lot of pleomorphism, and there is a lot, and there are few sheets and with no particular pattern. So Preeta, what would you think here?
It can be medulloblastoma. That is also anaplastic large cell type.
Okay. Any other differentials?
Atypical teratoid tumor, teratoid or rhabdoid tumor.
That's an important differential here. Vesicular nuclei with prominent nuclei with some amount of cytoplasm. Actually, I would place that before medulloblastoma. Okay, on morphology. Okay, then what else? Anything else? Any other thought? Anybody? Any other thought? No? Shall I move on? So yes, we did have, of course, a differential of ATRT and medulloblastoma large cell anaplastic type, but we did also wonder that could it be any of the rarer other CNS embryonal tumor, or because of the pleomorphism in giant cells, could this be just a high-grade glioma? Could this be a non-embryonal tumor? So those with this kind of pleomorphism in multinuclear giant cells are seen. You have to start thinking laterally also, not just because it has been called a medulloblastoma, but is it possible that these kind of can these kind of differentials also enter the picture? You always have to keep an open mind. So we did the first two IFCs, INI1 and BRG1, and what are they showing, Preeta?
INI showing diffuse positivity in the tumor cells. That is, there is no loss of INI1.
Exactly, and same for BRG1, which is the other IHC that we use for ATRT, which is very less commonly lost, but it shows a similar pattern, that is loss of expression, just like INI1. It indicates while INI1 is the same kind of retention or expression. So both of them are retained. So it is not an ATRT. That much is sure. Okay. Then we move on. And now this is the synaptophysin. This we did desmin to rule out rhabdoid type of appearance or medulomyoblastoma because the cells were showing some cytoplasm which is negative. The reticulin is not increased. We did OLIC2 for looking for glial differentiation, which is also negative. And of course the MIB is quite high. So again, from our differential list of differential, we're coming back to an embryonal tumor, likely medulloblastoma. So and with the histology, we did think that yes, this is a large cell anaplastic histology. And so just to quickly, before I come to the diagnostic IC, that is the differentiating IC, GAB, YAP, etc. Just to again give you a small recap of the medulloblastoma, which the molecular defined ones include, as I have already told, the Wnt, the SHH, the non-Wnt, non-SHH, and the histologically defined. Now histology is considered, as I said, now the morphological pattern only within a medulloblastoma, not a subtype. But it is important to give, when you're giving a diagnosis, to give the histological pattern along with the diagnosis, because each of the histological patterns have their own clinical association as well as molecular association. So, for example, classic type, in which is seen in predominant types of most of the medulloblastoma, where you just have diffuse sheets of uniform round cells. You might have one or two scattered nodules here and there, but by and large, that is not a dysplastic nodular. You just have diffuse sheets of round cells, and again, they do not have marked. Though they are all small round cells, they do not have marked pleomorphism or large nuclei with vesicular nuclei. And this kind of histology, the classic histology, it can be seen in any subgroup, but predominantly in the non-SHH groups, that is the Wnt and the non-Wnt non-SHH. Then you have the dysplastic nodular, the case you just saw, which is present in around 20% of medulloblastoma, but more commonly in infants, and it is most commonly associated with an SHH type of medulloblastoma. Important correlation here also when you give a dysplastic nodular pattern in your diagnosis is that the patient might need testing to rule out syndrome because there's a high association, about 20%. Similarly, for an MBEN, you have, this is what I wanted to show, that you have predominantly neurocytic nodules, differentiated nodules with very scant internodular zones, and the nodules are predominantly back to back with this neurocytic fibrillary stroma with streaming of the neurocytes within them. This is known as the MBEN histology, which is quite rare actually, and you should try not to call, you should look for the nodularity in a dysplastic very carefully before you call something as MBEN, that whether it is back to back or whether it is predominantly thick internodular zones with less of nodules. So this is also seen in infants in 20% of cases and also associated with an SHH activated type of medulloblastoma, and it has an association with Gorlin syndrome around 40%. So again, if you give this kind of histological diagnosis, the patient might need to be checked for syndromic association. And then we come to the large cell or anaplastic. So anaplastic was the case that I showed you that was having marked pleomorphism, while a large cell type is the one that actually almost looks like a lymphoma. More uniform cells, but all having vesicular nuclei with prominent nucleoli. This is again a rare subtype, and the most common association of this large cell is either in a non-SHH group 3, which is the worst type of medulloblastoma, but you can also see it in an SHH activated and P53 mutant type of, which is another subtype of the molecular subtype of medulloblastoma. So when we come to the molecularly defined, now this spectrum, as I said, is the Wnt, the SHH group 3 and group 4, which is the non-SHH, and within these also there are multiple subgroups. I will not go into too much detail because that is not relevant, but suffice to know that within the major subgroups, there are certain molecular alterations which give the risk of how the patient is likely to behave. For example, if you have a MYC amplification, the survival of an SHH drops from a good subgroup around 88% to around here 69.8%. Similarly, if you have between the group 3 and group 4, there are certain alterations. Again, here the MYC amplification where the survival drops very low, around 42% only, while the group 4 is, in certain alterations make it much better. And in this way, if you are able to identify besides the subtype, that histological subtype, if you are able to say which is likely to be a molecular subtype and give certain molecular testing which are indicative of the worst biology, and you say that this is present or absent, accordingly the patient can be treated. So so the testing platform GAB, YAP, and beta-catenin, and besides that, as I said, recently OTS2 and LEF1 can be used for subtyping these medulloblastoma, and very importantly P53, which is considered an acceptable surrogate for P53 mutation status. And so in these two cases that we saw, so beta-catenin was negative in the nuclei, GAB1 was positive, and YAP1 was negative. And in the first case, P53 was wild type, the dysplastic nodular case, while in this particular case, the P53 was diffusely strongly nuclear positive. So in the first case, if we put the GAB, YAP, P53, and beta-catenin, we can see that it was negative, positive, and YAP was kind of negative, and P53 wild type. So this was, though histologically we call it dysplastic nodular, if we put this panel, we can say it was an SHH activated P53 wild type. And for the next case, though it was the beta-catenin negative and GAP positive, this was P53 mutant type. So this was a medulloblastoma which was SHH activated and P53 mutant. So you are able to give, in the base of histology as well as combining with this IHC, you are able to give a molecular diagnosis, a surrogate molecular diagnosis. Now WHO also gives the essential diagnostic criteria for each of these medulloblastoma as a box of essential and the desirable criteria. Histology for the SHH being that dysplastic nodular, MBEN, less commonly classic and even less commonly large cell anaplastic, and this pattern along with the P53 mutation can help us give a diagnosis. And this is the schema that is used for the diagnosis of medulloblastoma. If you have an embryonal tumor in the posterior fossa, first of all, always you have to rule out other entities by doing a different IHC panel to rule out whatever your histological differentials are. And then if you think this is definitely a medulloblastoma with evaluation of presence or absence of nodules, the extent of dysplasia, anaplasia, large cell change, you can make a histological diagnosis of classic, dysplastic, MBEN or large cell. And then if you're able to add IHC and or FISH or gene expression profiling to give this kind of molecular subgrouping, and you can give an integrated diagnosis of the medulloblastoma with the genetically defined category. Now coming to the next case, case 2, which is a 2-year-old girl with again a short history of seizures since 20 days. Amit?
Okay. So the images above are post-contrast T1 fat set images, and the image below is a coronal T2 image. And what we see here is again a well-circumscribed mass which is present in the right frontotemporal insular region. It shows heterogeneous post-contrast enhancement. Again, it is the solid component is predominantly ISO2 hypointense on T2 imaging. So I believe on diffusion weighted imaging, this was showing restriction of diffusion with these kind of features, that is diffusion restriction, T2 dark or hypo to isointense appearance. I would again consider the possibility of embryonal tumor. An important differential, especially in the supratentorial parenchyma, would be an ependymoma or even a diffuse hemispheric glioma. So in the supratentorial parenchyma, it is in fact all the more difficult to differentiate round cell tumors like embryonal tumors, ETMRs, B-cord tandem mutation tumors, neuroblastomas from glial tumors like diffuse hemispheric glioma, or even from an ependymoma, because all of these can demonstrate variable amount of diffusion restriction and T2 dark or hypointense appearance. So wide range of differentials, with prime differential being a embryonal tumor, thereafter an ependymoma in this age group, thereafter a diffuse hemispheric glioma. Again, another companion case. So my apologies for some labeling error. So actually the GR image is the image on the bottom. The first image in the bottom row is GR image. The other labeling is okay. So the first image in the top row is T2 weighted image. The second image or the middle image in the top row is diffusion weighted image. The third image in the top row is a T1 non-contrast or unenhanced T1 image. Thereafter, the first image in the bottom row is a gradient image. The middle image in the bottom row is an ADC map, and the final image in the bottom row is a post-contrast T1 weighted image. So what we have here is again a mass which is present predominantly in the midline, in the frontal lobe, perhaps involving the genu of the corpus callosum, extending in both the frontal lobes, having somewhat well-circumscribed appearance, is iso-intense to the gray matter, not hyper-intense. The solid component is predominantly iso-intense. And then we have cystic or necrotic areas which are bright or hyper-intense. And the solid areas demonstrate diffusion restriction because this is bright on diffusion weighted imaging, the middle image in the top row, and is dark on ADC map, which is the middle image in the bottom row. And on T1 on enhanced image, we can see that there are certain T1 bright areas, which could imply that there is hemorrhage within the tumor, as can also be appreciated on the gradient image, that is the first image in the bottom row, when we can see some black areas or black spots, which imply that there is a tumor hemorrhage. And on T1 post contrast image, there is heterogeneous enhancement. So with all these features, a highly cellular tumor, prime differential is an embryonal tumor, can be ETMR, can be ATRT, especially if the kid is under 2 years of age, can even be a diffuse hemispheric glioma or an ependymoma. So these are some of the differentials on imaging.
Great. Thanks, Amit. So we will start with Parimi. Srijan. Parimi, are you there? If not, Vivek, would you like to take this? Vivek? If not, we come back to Ekta.
Ekta is not there, ma'am. Vivek is there. He's unmuted, but I don't know.
Vivek, could you describe?
Ma'am,
Yeah, go ahead. Go ahead. I think they have some internet issues. Then again, maybe Shivangi, would you like to take this? We cannot hear Vivek.
Ma'am, so the first slide is showing that the tumor is kind of, the lesion is very much cellular and has monomorphic type of cell, and it is infiltrating into the surrounding normal parenchyma.
Okay.
Ma'am, here we can see that on a higher magnification, the cells are more of a monomorphic, and they are kind of oligodendroglial-like or some neurocytic differentiation. But the important thing is that the cells are arranged around the vessels, and they are giving appearance of multi-layer rosetting.
So I would just like to add here that if you see here on the right hand side of the screen, this is actually the normal tumor brain interface. Okay, so if you saw the radiology, the tumor was quite relatively well circumscribed. Isn't that so? So what you have inside here is all tumor. It is not. This is not normal brain parenchyma. Okay, this is whole thing is tumor here. Okay, so you have areas that are more blue looking, and then you have areas that are more with clear cytoplasm and more fibrillary appearance. Okay, so there are two types of areas here: tumor cells which are having more fibrillary areas, clear cells, and then you have these undifferentiated, more round blue cell looking areas, and this is the interface. Okay, so go ahead.
So ma'am, the areas which are having a round blue cell like of morphology, most of the cells, they are arranged in sheets, and somewhere the cells are arranged in a rosetting manner, that is in a multi-layered format.
In between, would you like to say what this is?
And this is showing the necrosis.
Yeah. So what are these?
Where, ma'am?
On the left hand side. On the left hand side image, can you see?
Yes, ma'am. So ma'am, this is actually in center we are having a vessel. Surrounded by that, we are having some neuropil, that is acellular zone, and then the rounds are arranged in multiple layers around the vessel. Whereas the right image is actually showing that the lesion is very much cellular and has a very high mitotic activity.
Yes. So you have a tumor which is having hypo and hypercellular area. There are, in addition, there are the more of a matrix with lot of neuropil. Yes, lot of neuropil is there, and then you have these undifferentiated round cell areas which are arranged in rosettes and perivascular rosettes, multi-layered rosettes, and they are having necrosis and high mitotic activity. And here, what do you think what this image is showing? What kind of a rosette is this? This one. Yes.
Ma'am, the screen is not moving, ma'am.
Ruchi, can you see?
Yes, we can see.
Yeah. So what I'm showing here there are two different types of. This is what I described earlier as flexner interstitial type of rosettes, in which you have tumor cells arranged around a lumen with cytoplasmic processes. So you have flexner interstitial type of rosettes, multi-layered rosettes, neuropil-like material, abundant neuropil-like material, and neurocytic differentiation, as well as large undifferentiated round cells. So differentials here, Shivangi?
And the first differential would be ETMR, that is embryonal tumor with multi-layered rosette.
Yes.
And second, because somewhere I was able to see oligodendroglial-like morphology also. So, and it is for
yes,
a high-grade oligodendroglioma or rosettes are seen, so there can be a high-grade ependymoma as well.
Okay, so oligodendroglioma will usually not show you rosettes and the undifferentiated round cells as you saw. So yes, I agree with the ependymoma. So again, in a view of young age, we, regardless of morphology, we sometimes tend to keep ATRT as a differential, because ATRT can show you a variety of morphological patterns. So in a very young age of a child with an embryonal tumor in the differential, always have an ATRT at the back of your mind if it is not something totally classical. So yes, theoretically, yes, ependymoma, ETMR, and ATRT, these would be the differential. Now, as Dr. Amit was mentioning, that the diffuse hemispheric glioma is something he would keep. But yes, I would agree with that if they were not for the presence of the typical the flexor interstitial type of rosettes. Only the perivascular arrangement and the necrosis and the different types of oligo-like areas and everything, that would definitely fit in with the diffuse hemispheric glioma, but not with the presence of the typical rosettes. So in this case, we did immunohistochemistry for L1 cam to rule out what did we try to rule out with L1 cam? Can anybody tell me?
Ependymoma.
Yes, so this L1 cam. So now this picture I specifically put to show you that this looks like it is a positive stain, but actually in the undifferentiated round cells it is completely negative. So L1 cam is to be interpreted when it is only, when it positive is only when it is completely strong, diffuse all through the tumor. Okay, and P53 is wild type. Synaptophysin is positive quite nicely in the round cells, as well as of course highlighting the neuropil. INI1 we always try to do in very young age children, that it is retained. And then we also did VCOR, because VCOR can also CNS tumors can also show multi-layered rosettes sometimes, and undifferentiated morphology it was negative. And of course the MIB1 is extremely high, as you can see. So this is LIN28, which is highlighting a diffuse strong positivity all throughout. Here also you have to remember the LIN28 has to be diffuse strongly positive all throughout the tumor. Focal positivity, moderate positivity, weak positivity you can see in a lot of tumors, but diffuse strong positivity is the only one that is to be considered positive. And when you see this, if you want to do a confirmatory molecular testing, what would you do?
C19MC.
Yes. So this was also done in this. Shivangi, would you like to explain this slide?
So, ma'am, this is actually a FISH technique in which whenever the patient is having ETMRT, and in that case, C19 stands for chromosome 19 microRNA cluster amplification. So, the green signals are that for amplified signals. So, we are able to see that in single cell, a lot of green signals are present.
Yeah, so the green signals are definitely much more than the red signals.
Red
There is C19 amplification, which is the genetic alteration we look for in ETMR.
ETMR.
This is an ETMR confirmed. Now, can anybody tell me what are the various entities which were earlier called different names but are now included in ETMR?
So, ma'am, it was medulloepithelioma, ependymoblastoma, and etender.
What was
That
the
is embryonal tumor with abundant neuropil and true rosettes.
So this is what an etender looks like.
Etender.
Yeah.
Yes.
Embryonal tumor with abundant neuropil and true rosettes. Okay. So this is a classic morphology of a etender. Now, because of the presence of this neuropil, sometimes if you do not have the tumor interface, you tend to get confused that whether you are looking at an ependymoma, because in the background of ependymoma, this looks like a normal brain, which is infiltrated by clear cells, as you said, which is a common pitfall that because ependymoma can also have oligo-like clear cells. That is a subtype of cell that you can have. So it starts looking like an ependymoma, and in that, if you have weak L1 cam here and there, then you might end up calling this an ependymoma. So that is a pitfall that you have to remember, that where the term now what is called ETMR comprised of entity which was etender, which is about embryonal tumor with abundant neuropil and true rosettes, which is the classic morphology that was seen in this case. Okay. Also, so just a little bit about the ETMR. They occur mostly in children less than 4 years, and they are located in supratentorial location. Sometimes we have seen in intratentorial in the posterior fossa also, and they exhibit metastasis into the neuraxis very less commonly, but still they're very aggressive with an average survival of only 12 months even after intensive therapy. And these are the essential and diagnostic criteria for ETMR. Most of the time you're able to make the diagnosis in morphology and IHC only, and you have to remember these three patterns can come. Middle epithelioma, if you know, is a more of a ribbons and trabecular type of pattern, and etender is the type of pattern I've shown you. Then you can have most of the time, more than 90%, you have the C19 MC alteration, but there is a smaller association of dicer mutations also, which occurs in only around 5% cases. And only if you are not able to resolve this with the IHC and the morphology, and you're still having suspicion of ETMR but not able to confirm, then only do you need a high molecular testing. Most of the time you'll be able to make a diagnosis with the help of morphology and IHC. So the next case, any other student who has not spoken till date would like to volunteer? I think Vivek was around. Vivek, can you try to unmute yourself?
Yes, ma'am.
Yeah. So would you like to take this case? Before you start, let me ask Amit. So this was a 2-year-old male with again a short history and a posterior fossa lesion.
So again, beginning with the images, we have a T1 unenhanced image in the top row, the first image. The next image in the top row is the T1 post contrast. Bottom row first image is T2. Bottom row second image is ADC map, and third image in the bottom row is DWI. So we begin with T2 imaging, wherein we can see that there is again a large mass which is present predominantly in the midline, perhaps in the fourth ventricle, effacing the fourth ventricle, with solid component which is appearing isointense to hypointense on T2 images, and on diffusion weighted imaging, this is showing diffusion restriction, that is, it is bright on DWI and dark on ADC maps, and shows florid post contrast enhancement. So since this is a kid who is 2 years old, and with these features, the differentials would be embryonal tumor like medulloblastoma and ATRD. So these are two major differentials, and the other minor differential can be an ETMR, but less likely compared to the other two differentials. Again, this is not an ependymoma or a pyocytic astrocytoma, because we see florid diffusion restriction on diffusion weighted imaging and ADC maps.
So Amit, just if I can ask you here, suppose if you're thinking of medulloblastoma, would you care to hazard a guess of which type of medulloblastoma?
So this is a tough one, but given the enhancement, this can be SHH, given the enhancement, because non-WNT, non-SHH seldom show as avidin enhancement as is seen in this tumor. So perhaps an SHH medulloblastoma.
Okay, great. So Vivek, you're up.
Yes, ma'am.
Yeah, go ahead.
Tumor cells are showing hypercellular and hypocellular area, and
yeah, now
now we can see some rosette formation.
What kind of rosettes?
It can be, I think,
What do you have at the center of the rosette?
lumen.
So if it and is the lumen containing anything?
Yeah, ma'am. Blood vessel, I think.
Yeah. So it is. If there is a rosette around blood vessel, what kind of rosette is it?
Homocyte rosette.
No. It is a perivascular pseudo rosette. There is no blood at the center and only lumen, which is not lined by endothelial cells. Here, if you can see, it is lined by endothelial cells. So if there is no endothelial cells and no and then no RBCs, then only we will call it a homocyte rosette. When there is blood and endothelial cell line spaces, then these are perivascular pseudo rosettes. Okay, so you are seeing pseudo rosettes, and now so is your screen moving?
No, ma'am.
Do we have to wait for it to catch up?
I think we can see the things like.
Yeah. So again, I'll just add to his description that he described that there are areas with hypo and hypercellularity. Okay. Also, there are areas of necrosis here, and then there is low power only. You can see that there is some perivascular arrangement here and there. And in this power, we can see the prominent perivascular arrangement with again multi-layer type of rosettes around blood vessels. And on higher power, you can see that the hypercellular areas are packed with round blue cells, and the less cellular looking areas on the low power are actually also packed with cells, but they are more pink with more cytoplasm. And this is a higher power image. Vivek, if you are able to see now, would you like to add something?
You can see rosette formation only, and there are some oligodendrocyte-like cells. We can see, ma'am.
So actually here there are no oligo-like cells. What you have is cells with abundant cytoplasm. At some places the cytoplasm is eosinophilic, giving it a more pink appearance, while some places it seems to be a little bit of a clear cytoplasm. So these are very, very large cells. I would not call them oligo-like here. And yeah, so again, very undifferentiated looking cells. You can see there is a lot of pleomorphism with some vesicular nuclei starting to appear, and some cells with eccentric nuclei. Can you see here?
Yes, ma'am.
Yeah, eccentric nuclei, abundant cytoplasm. And then you have what kind of appearance is here? Anybody would like to say?
Rosette.
Again, rosette. What type of rosette here?
This one is homocyte, I think.
Yes. So we are having round cell areas with homolyte rosettes, and we are having a lot of mitotic activity. So again, blue cell areas, more pink areas, and rosettes are there.
Yes,
So, and again, this is, can you describe this? The last image?
the cells are showing pleomorphism, ma'am.
And
Ma'am, nuclei is seen.
yes, and dense pink cytoplasm. Yeah,
Dense pink cytoplasm.
and vesicular nucleus with prominent nucleus. So Vivek, differentials?
I think one is, I think, ma'am, ependymoma, ma'am.
Ependymoma with vesicular nuclei, prominent nuclei? No? Do you have vesicular nuclei with prominent nuclei in ependymoma? Well, there is a variant, epithelioid variant of ependymoma. You're right, that can have, but it will be lower down. What would be the first differential you think of? Anybody like to chip in with differentials here?
Ma'am, can be ATRT first,
Okay.
and second can be ETMR.
Yes, very well said. Somebody has, yeah. So yes, we had a lot of differential. Of course, ETMR with the multi-layered rosette was also top of the list. Ependymoma with epithelioid features, ATRT, and I cannot think of anything else. But sometimes you can have glial tumors also, which can show this kind of, because you can have undifferentiated areas and cells with more rhabdoid/gematocytic type morphology also. So glial tumor also you should always keep at the back of your mind in a posterior fossa lesion. So we did OLIC2, that is here and there focal positive, desmin negative, A1, A3 is focally positive here and there in large cells, synaptophysin is positive, and the Lin28 here you can see is negative. So Vivek, what do you think now? So is OLIC2 positive in ependymomas?
No, ma'am.
No. Lin28 is so what is ruled out?
ETMR.
And you have positivity for OLIC2, A1, A3, synaptophysin. So what kind of positivity, what kind of phenotype is the tumor having?
Glioblastoma.
So it is having a polyphenotypic phenotype. It is having multiple lines of differentiation. You're having differentiation along epithelial lineage, some amount of glial lineage, as well as the neuronal lineage highlighted by synaptophysin. And it is negative for desmin. We did that because we were seeing what kind of cells? Rhabdoid cells. So they're having polyphenotypic differentiation, and it is not an ETMR. So what IHC would you do for confirmation here?
INI. INI1.
Yes. So we did an INI1, and what is it showing?
Lost, ma'am.
Loss. So you can compare it with the endothelial cells, which are showing diffuse
Positive.
nuclear positivity. While here, though you have some amount of cytoplasmic blast, the nuclei are all negative. And also this is BRG, which we do always as a companion, and it is showing retained expression, nuclear expression in all the tumor cells. And the tumor is wild type of P3, which we also do for all embryonal tumors. So diagnosis is an atypical teratoid rhabdoid tumor with the loss of INI1 expression. Now, just to give a small brief description, ATRTs are poorly differentiated tumors which can have variable rhabdoid cells. I tried to highlight that you were having areas with rhabdoid cells. Sometimes in low power it is difficult to make out when the cells are so tightly packed, and you have to go and look for them in the high power. And you can also have areas with completely round cell appearance, as we saw in some areas of this tumor. There was a completely undifferentiated round cell appearance. And as we saw, there are multi-layered rosettes also. So that is why I said, whatever the morphology, you always must keep, when you're thinking of an embryonal tumor in a young age, you must always keep a differential of ATRT, which is easily diagnosed by one simple IHC stain, and you will not miss the diagnosis. It can show a variety of morphologies as well as a variety of IHC patterns. So you have to remember. And if you have the loss of INI1, that indicates that the tumor is having deficiency of SMARC B1. And if you have a loss of BRG1, which is less than 5%, you are having a deficiency of SMARC A4. So these are again rare tumors, less than 2%, but in the infantile age group, they form a big chunk, and they have uniformly poor prognosis. Now you have in the ATRT, in the upcoming next WHO classification, there is a proposal that there might be addition of the further molecular subtypes of ATRT. So just to familiarize that there are 3 different molecular subtypes hidden within them, and according to the molecular alterations that can be present, and it is important that the mixed subtype is usually the one that is going to show the worst prognosis. So this is a proposed classification. It is not yet in the WHO, but just to give you, by the time you are senior residents, you are going to have most likely this classification also that will be required. So again, the diagnostic criteria of ATRT include a CNS embryonal tumor with a polyimmunophenotype. You can have a multitude of markers positive, and that is like you can have A1, A3, you can even have synaptophysin, OLIC. So you can get confused with, if you do only one marker, you can get confused with the differential. So if you do a panel of markers, but the important thing is that INI1 you should definitely do if you're thinking of an embryonal tumor, regardless of morphology. And if you're able to demonstrate the loss of INI1 or BRG1, that is generally considered evidence enough, surrogate evidence for loss of the SMARC B1 and SMARC A4, and it is considered diagnostic. So just to give you a small approach of the non-medulloblastoma type of embryonal tumors, if you have an intracranial tumor with embryonal features, again, first of all, you have to rule out other non-CNS origin or any other glial origin differentials. And then if you are sure that you're looking at an embryonal tumor, first of all, you should try to do an INI1 BRG1, because if it is lost, you have the diagnosis of ATRT. A crinate is also another embryonal tumor, but that is again more towards the extra-axial location. And then if you have INI1 BRG1 retained, and then you look for the multi-layered rosettes, and then you try a Lin28. If it is present, then it becomes an ETMR. If it is absent, then you do an OLIC2 staining. And if it is diffusely positive, then you have to consider a FOXR2 activated neuroblastoma. If there is only OLIC2 in subset of cases, you can add BCOR IHC, so you can confirm with the BCOR ITT type of CNS embryonal tumor. And then you have to only, after these basic panel of IHCs and this thing you have tested, then you can go for advanced testing if required, or refer for advanced testing to rule out any other subtype of embryonal tumor. So case 5. So this was a 2-year-old male, and in this, Amit, would you like to chip in again?
Yeah. So this is a tough one, really. Okay. So we have T1 post contrast in the top row first image. Second image is T2 flare. Third image, the bottom row first image is ADC. Bottom row middle image is T2, and then diffusion. So we can see that there is a there is an area of altered signal intensity which is present in the extraxial location, predominantly along the left cerebellomedullary cistern. It can also be involving the adjacent bone, that is the petrostemporal bone, and it is extending somewhat into the left internal auditory canal. It is showing a diffusion restriction, a feature of high cellularity, and also a feature of embryonal tumors. So this is again some extraxial embryonal tumor, perhaps an Ewing's or any other embryonal tumor. So those are some of the.
So this was a tough one. Yes, I agree for us also. But what we received was a tumor along the left, as a posterior this CP angle lesion. We did not know about the extraxial location when we started seeing the slides. So we received it as a CP angle lesion and in the posterior fossa. So who has not taken till now? Is any of the student who has not taken available? If not, I will ask Preeta again.
So the section shows monomorphic cells which are arranged in diffuse sheets, and these cells have scant cytoplasm, round to oval hyperchromatic nuclei, and inconspicuous nucleoli, and a mild degree of nuclear pleomorphism. And I think in some figures, rosette-like structures are also seen.
Yes.
And there are a few mitotic figures are seen as well.
Yes. So actually not much to go on, just undifferentiated kind of round cells. But if you see the pleomorphism, as Preeta rightly pointed out, is quite minimal. There are not much pleomorphism, quite uniform round cells, and with presence of rosettes and just back-to-back appearance without any kind of particular histological feature that I can pinpoint. So Preeta, what would you consider here as a differential?
My first differential is maybe an Ewing sarcoma.
Yes.
And an ATRT maybe.
Of course, you must always. I said the history is a 2-year-old child, so you must definitely keep a possibility of ATRT. Very good. At least that much you have taken away, that in a young child always keep a differential of ATRT. Yes. Go ahead. Anything else?
Can it be a posterior fossa ependymoma?
Okay. Maybe, but there is no pattern as such. There is no perivascular glial matrix, and so not maybe high on the list. So actually, I did keep a differential of a classic type of medulloblastoma. I also kept a differential of a weak or type of CNS embryonal tumor, because sometimes they can show again a variety of morphology with just back-to-back sheets of round cells. So besides that, since now we went back to the radiology with the CP angle tumor and we got to know that it is more of an extra-axial meningeal based thing, so we kept a differential of most of the meningeal based round cell tumors which can involve the basically extend into the cranium from outside, that is from the meninges or the bone. So all those differentials, can anybody tell me what would be the differential of a meningeal based round cell tumor? Preeta? Besides Ewing's that you mentioned, anything else? Any other round cell tumor that can involve the meninges and the skull bone or the skull bone?
Rhabdomyosarcoma.
Yes. Somebody has mentioned lymphoma. I agree. Yes, you can very well have a lymphoblastic lymphoma involving the meninges. Anything else? So you can also have, mesenchymal chondrosarcomas, which also look Ewing-like, and of course you can have the Ewing's family of tumors. There are a lot of expanded family of Ewing-like tumors in the soft tissue. So any of the soft tissue round cell tumors can also involve the meninges, basically, because meninges are the soft tissues of the brain. Okay, so they are the counterpart of the soft tissues in the periphery. So you can have the meningeal round, any kind of round cell tumor that can involve the soft tissue can also involve the meninges. So with here actually radiology was very helpful for us to kind of narrow down our IHC panel to the meningeal based round cell tumors. So in this, though we did put the INM1 and BRG1, we never forget that, which was quite retained, you can see. But here we did Desmond to rule out, as well as OLIC2 to rule out glial, as well as the rhabdomyoplastic or rhabdomyosarcoma. The synaptophysin was patchily positive, but what was intensely positive, as you can see, was the diffuse, strong, membranous MIC2 expression, and with its counterpart NKX 2.2 being strongly diffusely positive in the nuclei. So Preeta, what would be your diagnosis here? Hello, anybody else? I think we lost the signal. So what is, with the presence of MIC2 and NKX 2.2, what is the diagnosis? I hope I am audible.
Yes, you are audible. Shivangi can respond. She's the only one who's ever.
So diagnosis of NKX, yes. So this was a Ewing sarcoma. So always again, besides the differential of the intracranial soft tissue tumors, you also have to keep, when you're seeing a round cell tumor or an embryonal tumor, you also have to keep in keeping with the radiology. If the tumor is meningeal based, then you also have to keep in mind that there are a number of meningeal based round cell tumors, which can be, because they are arising in the meninges, they can extend downwards and grow into the brain parenchyma and present like a intracranial mass. Even though it is meningeal based, the differential it is present as a differential of an intracranial mass. And according to the WHO, these are the tumors which can show, which are the mesenchymal non-meningothelial tumors, RMS. Then you can have CIC-Lerin sarcoma, primary intracranial sarcoma, dicer mutant, Ewing sarcoma, mesenchymal chondrosarcoma, and also a recently described tumor known as an intracranial mesenchymal tumor, FET fusion positive. Besides these, there are other non-meningothelial, non-mesenchymal tumors which can involve the brain and sometimes present as differential, the dural lymphomas, sometimes metastasis, mostly in the adults. Inflammatory lesions can also present as tumors in the non-meningothelial, meningothelial based tumors, and sometimes gliosarcoma and oligodendroglioma, though not in the young age. So these are the host of differential that even if you have meningeal based tumor, you know from the radiology that it is meningeal based, you have to keep a lot of differential at the back of your head. So this brings me to the last case, case 6. I'm sorry, Amit, I do not have the radiology for this case. This was actually quite recent, just around I think a week ago I got the case. So any of the students would like to take this? So this was a 13-year-old male with again a short history, and I do have the radiological description that the tumor was around 4 to 5 centimeters in the left frontal lobe, and the tumor intraoperatively was dark, mildly vascular, easily suckable with areas of necrosis, and with poor plane of cleavage with the adjacent brain parenchyma. Can anybody tell me what this intraoperative description means? Anybody would like to volunteer here to tell me what this intraoperative description means?
So,
For us
ma'am,
as pathologists,
ma'am, it is showing that there is an area of necrosis and hemorrhage, which is suggestive that it is a high-grade tumor.
perfect.
And with that, there is a poor plane of cleavage with the adjacent brain parenchyma, so it is like diffusely infiltrating, not a circumscribed lesion.
Perfect. And also it is easily suckable. That also indicates many times you get the whole at least the easily suckable, non-suckable is usually included in the intraoperative notes. So what is non-suckable or difficult to suck is things like meningiomas, those things with fibrosis. While things with which are more intracranial or like round cell tumor, glial tumor, they are all easily suckable. Okay, and poor plane of cleavage indicates that there is some kind of a diffuse appearance of the tumor in contrast to the very nice plane of cleavage we had seen earlier in some of the tumors. So who would like to take this? Anybody? If Shivangi, you are there?
Yes, ma'am.
Yeah, please go ahead.
So here on low magnification, we are seeing the bits of various bits of tissue, and we are seeing that the cells, it is quite cellular, and the cells are arranged in a sheet, and there were few areas of hemorrhage. Then slightly on higher magnification, we are able to see that the cells are mostly monomorphic, and they have a high NC ratio. Some form of spindle cells are also seen, and there are few flattened vessels which are present in between. And here we are seeing that the tumor is mitotically very much active, and most of the cells are primitive cells, that is of small round blue cell kind of morphology, but few cells are showing spindle kind of morphology. We are able to see a lot of pleomorphism.
Yeah.
Yes, ma'am.
So here, just on the last slide, in addition, there are a few scattered giant cells also, multinucleate giant cells, and a lot of mitosis, including this atypical mitosis, this bird-like thing here. Yeah. So
Yes, ma'am.
pleomorphic, yeah, round cells, patternless sheets of round cells, no particular, no particular arrangement, and quite vascular tumor, undifferentiated round cell morphology with some amount of spindling, as you said, and some amount of pleomorphism with giant cells. So differentials.
So, ma'am, as it is in the frontal region, so it can be ATRT, it can be a high-grade glioma,
Anything else?
or also we can go with CNS embryonal tumor, we call ITD.
Yes. So I think you said ATRT. So actually, yeah, this is a 13-year-old.
Yes,
ATRT would be a
ATRT.
little lower down on the list of differentials.
Yes, ma'am.
CIC rearranged, somebody has said. So CIC rearranged, yes. But you know, the CIC rearranged little bit. The cells are a little bit big actually with multinucleate giant cells. So little bit unlikely. Anything else? So my differential actually in this case, actually if you see there is a little bit of a fibrillary background here. In between the cells and around the vessels. If some of you can see, around the vessels there was some amount of fibrillary background. So I did keep a differential of ependymoma also here. And with embryonal tumor I thought, but which embryonal tumor I was not able to pinpoint. So yes, high-grade glioma was also differential. So little bit because it was more of a patternless tumor without much morphological features, any specific morphological features. Again you have to think wide what all things it can be. So little bit of hints and clues here and there you have to look for. And what I latched onto was a little bit of the fibrillary background that this tumor seemed to be having here and there with the multinucleate giant cells. So these are my differentials, and I was not able to pinpoint if I have to think of at this age which embryonal tumor it could be. So I did a little bit. I did L1 cam for ependymoma, which is clearly negative. GFAP is positive. Yeah, you can see the GFAP is
Yes.
positive. Not only in the perivascular areas actually, which is highlighted. Perivascular accentuation seems to be there, but the tumor cells are also positive, and it is OLE2 negative. Actually, this combination is usually seen in ependymoma, but this tumor was L1 cam negative. Then ATRX was retained. IDH was negative. In a 13-year-old, we did think of a possibly a IDH mutant glioma. It is a little slightly towards a younger age, but you can get IDH mutant diffuse high-grade gliomas in this age also. So we did this. It was negative for IDH, and we did STK27ME3, which was retained, which we do for midline glioma.
Midline glioma.
So yeah, so this was retained. So this was not a diffuse midline glioma. It was high. P3 was mutant. And what is this? Can somebody tell me what does this indicate?
Ma'am, H3,
Yeah. So what is that?
H3G34R is actually done for diffuse hemispheric glioma.
Yes. So that is like an IDH. This is a mutant protein
Mutant.
IHC, which is a good surrogate for a H3G34R mutation. So if this mutant IHC is positive, that indicates that there is presence of this mutation, and it is a H3G34R mutant diffuse hemispheric glioma. So this was just to bring out to you that there are a lot of CNS tumors which can show an undifferentiated round cell morphology, which includes, of course, the embryonal tumors, but among the diffuse glioma, even adult type IDH mutant astrocytomas, the pediatric type diffuse hemispheric gliomas like this one, and even the pediatric type diffuse gliomas, IDH wild type, histone wild type, can all show you areas with undifferentiated round cell morphology. Besides that, of course, ependymomas, you have to keep pineal tumors in mind, but this location was, of course, non-pineal. And then, as I discussed earlier, meningeal mesenchymal tumors, and in older age, you also have to think of metastasis. So if we remember if you're thinking of an intracranial tumor with embryonal features, you always, and this is included in this flowchart, if you remember, high-grade glioma, G34R or V mutant has to be ruled out before you move on to a CNS embryonal tumor. Okay. So and also this patient was though 13, little bit towards the lower spectrum, but would kind of fit into the spectrum of adolescent and young adult age group. And this is in this age group actually CNS tumors are one of the most common causes of cancer-related death, but they have overall a better prognosis than brain tumors in older adults. Hence, they are more likely to have survivorship issues. But the diagnosis here becomes important. Why? Because if you see the spectrum of CNS tumors which can involve the adolescent and young adult age group, it is basically a mixture of what you can see in the children and adolescents as well as what you can see in older adults. So the whole kind of combination of these tumors you can see in the adolescent and young adult population. So even if you are seeing something like a 17, 18-year-old or even a younger adult like 20, 21, you cannot rule out embryonal tumors as well as a whole gamut of differential. So this was just to bring out that you can have something with an undifferentiated round cell morphology which can be differential of an embryonal tumor, but is actually a glioma, as well as to bring out that in the adolescent and young adult population also you can have a good number of embryonal tumors. So you have to keep both the differential always in mind. So just to take two messages that the CNS embryonal tumors are a heterogeneous population, and you must always have a wide array of differential diagnosis and cast a wide net. And the site, the pattern, radiology, histology, and IHC, you have to do this appropriately so you can choose what molecular testing you should do further. So with this, I would like to conclude, and yeah, I will stop sharing my screen.
So, ma'am, I have a question.
Yeah.
Well, the last case number 6, in that can't it be BCOL one? Because when the cases shared at that time, I was thinking it would be BCOL positive.
Yeah, so that again, BCOR ITDs have a little bit slightly more uniform round cell morphology. What you start thinking of, differential of ependymomas or astroblastomas, that kind of morphology is something that you see, that more of a papillary type of arrangement. You can see pseudopapillary arrangement. You can see round cell resembling evening-like areas. So that kind of morphology. This was completely diffuse sheets without any kind of pattern, and there was a very thin fibrillary background to all the cells with the presence of multinucleate giant cells. So when you have basically the tumor was not giving many clues on the morphology. So you have to kind of pick inside and check whether you can kind of. So I would not say that I did not consider BCOR ITD. I ran to the whole list of CNS embryonal tumors. That can any of these look like this morphology? So, but first differential that would be there would be more of a glioma that I would like to rule out, and even a differential of ependymoma before I move on to the actual embryonal tumors with that kind of morphology. So most of the embryonal tumors you saw, they do give some kind of clue or pattern and some kind of arrangement that you can suspect. So that is why this was glioma was top on my list, and first I did in the first panel only. If you are able to get, then you don't go on and doing BCOR and everything. I did do BCOR in several other tumors. If you saw, I took the IC. I do have a case of BCOR ITD, but I don't think I put it in the PPT because it was getting too much. So but yes, so BCOR ITD definitely, but it does have some kind of morphological clues which were not there in this case.
Thank you, ma'am.
So actually you thought of BCOR ITD because you thought okay, all the embryonal tumors must be getting covered. So BCOR ITD is the one by exclusion that is left.
Yes, ma'am. Even when I read it, also they were saying that most of the cases of BCOR, they usually come with morphology same as that of high-grade glioma. So that is why I was thinking of BCOR.
Yes, it is a very common thing, and we would in many cases put a BCOR IHC, but this was completely patternless with a thin fibrillary background everywhere. That was just that little clue that there was a fibrillary background and spindling. That was due to also the fibrillary background.
Yes. Thank you. Thank you.
Anybody else?
Ayushi, I'm not seeing any further questions in the chat box. Thank you so much, Dr. Ayushi and Dr. Amit, for helping us understand this topic in a better way. I hope if there are no more
Thanks, Amit. I think your explanation for the neuroradiology was, I think, of great benefit to the students who don't, get to see, because most of the time all they get to see are reports, MRI reports, and I think they will be able to go back and understand what those reports mean, at least in the context of embryonal tumors today.
Yes, thank you, sir. So you're muted. Can you unmute?
Thanks for having me. I'm glad I could be of help, and I want to thank especially Dr. Gujral, Dr. Ayushi, and all the panelists and the team behind the slide seminars. So thank you all.
I would also like to thank the students. It is not easy to put yourself, out there and try to give descriptions, because I asked several of them. They had not seen embryonal tumors. Some of them had not seen many brain tumors before. So it was a very good interactive session, and I was able to get this good description and differentials out of them. It was quite good. And thanks to you, Geeta, again.
Thank you so much for the next slide seminar.
Thank you, ma'am. Really, it's a nice session.